Respected senior members amongst the august audience, dear friends and colleagues, a very good morning to each one of you. Assalamu alaikum. At the outset, I wish to put on record my sincere thanks and appreciation to Professor Hamad Athar and other members of Scientific Committee of 23rd Pakistan Association of Urology Surgeons Conference 23 for giving me this opportunity. This is the session on minimizing complications in PCNL for Staghorn stones, and I would be speaking on infective complications and prevention of these complications during PCNL surgery for Staghorn stones. I bring you greetings from Apollo Hospitals, Indraprasth Apollo Hospital, and Apollo Spectra Hospital in New Delhi, where I am working now. Specific issues pertaining to staghorn stones are two. They are large volume stones, they have extension in difficult access areas, they may require ancillary procedures, may require multi-staging, and may be prolonged surgery. But more important than that is most of the staghorn stones have associated infections. Either they are primarily infection stones, most of the staghorn stones are infection stones, or because of prolonged progress in the pelvic ileal system, the system gets infected and this leads to secondary infection. So take it for granted, all precautions must be taken to prevent septic complications in managing the staghorn stones because even in preoperative sterile urines, urosepsis following PCNL may occur due to release of bacterial endotoxins or viral bacteria during stone fragmentation. Incidence of septic shock following PCNL is only 1%, but mortality rate is 66 to 80%. We have to be extremely careful. The patient should not develop sepsis. 10 to 34 patients who develop fever after PCNL is uncomplicated sepsis. There is no need of change of antibiotics. Then there is hardly any rise of total leukocyte count. And without changing antibiotics within a day or two also, these patients become all right. But if there is a complicated sepsis, then we have to be careful. It has to be identified and aggressive treatment has to be initiated in the golden first 6 hours, which are very precious to save these patients. Because sepsis rapidly leads to sequential progressive organ dysfunction. All the systems get involved, and then it becomes difficult to save these patients. So, we have to do all preventive measures to prevent infection during stone surgery. Current AUA guidelines, they suggest if the preoperative culture is positive, give 5 to 7 days course of antibiotics prior to PCNL. But AUA guidelines are silent on the issue whether after 5 to 7 days we should do a repeat culture and then only touch the patient when the culture is sterile, or we can go ahead. If the culture is negative, they recommend only single dose of antibiotic prior to PCNL and no antibiotic after PCNL. But we hardly go with these guidelines because these are inadequate in our situation. There is only 43.5% correlation found between the preoperative urine culture and stone culture. So patients can still develop, in spite of sterile urine, they can still develop postoperative sepsis and septic complications. And therefore, we have to be extra cautious in all the three steps, whether preoperative phase, in intraoperative, and postoperative. I will give you an example of this case. This lady, 42 years female, on whom I had done PCNL 12 years ago and she was lost to follow up. She came back after 12 years with another staghorn stone on the left side, on the same side where I had operated. She had no comorbidities. She did not agree to the surgery in November when she came. After 2 months, in January 2019, she came back with severe left loin pain and fever with rigor since 2 days. Did her culture, which was Proteus mirabilis, more than 1 lakh colony forming units. This was the X-ray KUB. Quite obviously, she has a infection stone. After 3 days of antibiotics and conservative management, when she was all right, then we did a IVU, and it is suggesting, because we have already done 3 months back, we have done a CT scan. Can't do CT scan so fast again. So we did an IVU, and if you see this IVU and X-ray KUB carefully, you will be able to identify that this particular stone has come down into the ureter, has blocked the whole system, and there will be sepsis above this stone. So we had to, first of all, drain this system by putting a left digestive stent, and then this stone was pushed back into the kidney and stent was left in. She was put on antibiotics. After 10 to 15 days of antibiotic, on 15th of February, her urine culture was still showing Escherichia coli. And we again gave a second course of antibiotics according to the culture and sensitivity report for 7 days. She came back on 28th February, and this time urine culture was still showing Escherichia coli, but only 50,000 colonies. Even then, we did not agree for surgery, and I started her on nitrofurantoin, ranitidine, and vitamin C, 1 HS each. This is my standard protocol in these cases of Staghorn, because I follow this particular publication long back, and this shows that when you start this nitrofurantoin 1 week before, the septic complications are less. And this has been my experience also. So I put her on nitrofurantoin for 7 days, and now she was admitted on 7th of March. Hemoglobin was 11.4, TLC was 10,500, creatinine was only 1.33, X-ray chest, X-ray KUB were showing stones, and X-ray chest was clear. Under general anesthesia, she was operated upon, and the first aspirate, which on initial puncture I got, was little turbid in the beginning, but within 5 to 10 ml, and then irrigation from below from ureteric catheter continued, and the irrigation fluid, whatever we were getting, was clear. So we sent this turbid fluid first 5 to 10 ml for culture and sensitivity, and I continued with making a track between 12th and 11th rib on the left side, targeting this particular stone, and then all the stones, we made a 21 French track between 11th and 12th rib. I used 12 French mini nephroscope, almost 9 French difference between the, and then in between sometimes we used 19 French nephroscope also, and stones were very friable, and they came, some matrix was also found. Rarely only we had to break the stones, and these stones were fragmented and coming out easily. We used pressure pump with pressure irrigation, all the stones. Hardly ever we used the forceps also, but it took about 100 minutes to completely clear all these stones. At the end of the surgery, we left a double J stent and a nephrostomy tube. Our standard protocol in such cases is to continue with amikacin and ofloxacin, that we continue. On first post-op day, she had little more pain than usual. There was no fever, no tachycardia. She is anxious and tachypneic. There was soft abdominal distension, but bowel sounds were there. BP was maintained. X-ray chest and X-ray KUB were okay. So we thought everything is going on smooth. But on second post-op day, when she became little breathless, we found out by X-ray chest there is some collection on the right side of the chest. Mind it, surgery was done on the left side, but pain was more severe. I thought this so much of pain is because of a intercostal nephrostomy tube between 11th and 12th rib, and because everything was okay except for tachycardia, tachypnea, and 95% saturation. So we removed the nephrostomy tube, and we ordered for blood investigation. To our surprise, TLC was 40,000. Creatinine has risen to 4.87 milligrams. Immediately, amikacin was stopped. Meropenem was started. Post-operatively, every day we were managing her slowly. As per this, uh, uh, on the right side, the chest started becoming clear. but TLC was still not settling adequately. Creatinine was still rising. Added augmentin. Then again on sixth post-op day when we tested, creatinine was 5.05, LDH was above 100, procalcitonin was 144.2 microgram, urine culture was sterile, blood culture was sterile. So we continued to manage on conservative lines in ICU. TLC was gradually reducing, but creatinine was not settling down. So we gave antibiotics according to the guidance by the intensivist. On 11th post-op day, she became again breathlessness and saturation started declining. And we saw that there is a fluid collection on the left side of the chest now. So pleural effusion was there, 800 ml of fluid was drained. We thought if there is any perinephric collection or anything else, we must know. So CT scan was done. There were no residual stones, there was no perinephric collection. Surgically, she was done well, but this sepsis continued to trouble her for many days. On 14th post-op day also, she was in the hospital with severe vomiting, tachypnea, tachycardia. She was not able to eat, so we put a Ryle's tube, feeding was started, parenteral nutrition was started. Slowly, total leukocytes count was coming down, but creatinine was not coming down, and saturation on 17th post-op day was still 82%, and BP also was only 90 millimeter of this. So again, she was taken to ICU. Fluid was increasing in the left side. So we had to do intercostal drainage also by putting a tube. And with great difficulty, she started improving. And ultimately, on 24th post-op day, she was discharged from the hospital with the TLC of 7,400 and creatinine of 1.7. We have taken all adequate precaution. Preoperative antibiotics were given. Postoperatively, she was identified to be slipping into sepsis. She was shifted to ICU. All measures were adopted. ICU care, central line, everything was done. And therefore, we could save this patient. But with little renal dysfunction, her creatinine at the beginning was 1.33 and at the time of discharge was 1.7. So what went wrong and what we learned out of this? What I learned that there were little problem in intraoperative things because there was a maintained we although we maintained a 7 to 9 French difference between the size of nephroscope and the employed sheath, but we used pressure pump. Probably that caused rise of intrapelvic pressure and absorption of toxins and bacteria, and that resulted into sepsis. So this is the only thing which I pointed out because we know the pilovenous backflow starts as low as when the pressure in the pelvis is 40 to 60 centimeter. Cornicial ruptures start between the pressure of 60 to 80 centimeter, and fluid and infected fluid, bacteria and the toxins, they get absorbed into the system and they may lead to septicemia. So we have to be really careful. The best irrigation system in the world for ureteroscopy and PCNL is only gravity. So meticulous postoperative care also must be done in these cases to save them once they are slipping into sepsis. And for that, within 6 to 8 hours of surgery on on Staghorn stones, we must personally visit them and see them. Why? Because this surviving sepsis campaign has issued some guidelines. They say because sepsis leads to sequential organ failure, we have to do a SOFA scoring every day. We have to assess these patients postoperatively to see if they are slipping into sepsis. And for this, all these six systems respiratory, cardiovascular, hepatobiliary, coagulation profile, renal system, and neurologic have to be evaluated daily, clinically, by investigations, radiologically, and by biochemistry. And then the scoring is done from 0 to 4 for six systems. So score will come out to be 0 to 24, and then this has to be followed every day. This is a very big exercise, very difficult for we busy urologists. So another thing they have suggested is quick SOFA. This we all must know by heart. In quick SOFA system, You should visit your patient within 6 hours of surgery and see what is his or her systolic blood pressure. If it is less than 100, give a score 1. If her respiratory rate is more than 22, give another score. And if the patient is not as alert, intelligent, and cohesive as she or he was in the morning, there is altered mentation, then add another score. So if the scoring of quick SOFA is more than 2, your patient is going to slip into sepsis. Immediately shift the patient to care of intensive care, and then only you will be able to save these patients. We must learn quick SOFA system, see the blood pressure, see the respiratory rate, and assess their mentation, how alert or confused they are, and accordingly take a wise, calculated, immediate decision within 6 hours. Only then we will be able to save our patient. So, what I learned out of this patient was we have taken enough antibiotic, we have given enough antibiotics, adequate preoperative cover is a must. We should also keep a track of operative time. We should not go on operating for 100 minutes. We should stop the surgery if there is development of tachycardia. Always maintain low intrapelvic pressure. Never use pressure pumps in Staghorn stones during PCNL. And you should also look for signs of quick SOFA as we did in post-operative period to save these patients. Thank you very much for a patient listening. Thank you.